Next, I would like to bring up to the stage Dr. Veena Shankaran, who is a GI medical oncologist at the University of Washington Fred Hutch Cancer Center. She's an associate professor there and also faculty in the Hutchinson Institute for Cancer Outcomes Research at the Fred Hutch. Please join me in welcoming Veena to the stage.
Thank you very much, and I'm really grateful for this opportunity to talk to you a little bit about the role that the Hope Foundation and Coltman Fellowship played in enabling me to study this concept of financial toxicity in cancer care. So by way of background, I'm just going to show you a graph that many of you probably have seen before, but really illustrates the fact that the U.S. spends far more on healthcare than most other developed countries. And in fact, the cost of healthcare in the United States is increasing at a rapid rate every year. And as a result of this, we're seeing a lot of the costs of healthcare being shifted towards patients and families in the form of increasing premiums and out-of-pocket costs related to copays, deductibles, and coinsurance. Additionally, there have been a number of oral cancer drugs approved over the last number of years, which is obviously great in terms of improving patient outcomes, but is also important because many of these drugs cost in excess of $10,000 a month, and particularly in the context of multi-tiered prescription formularies, many cancer patients may be responsible for 20 to 30% of the cost of these drugs. Added to that, many of you may be familiar with this recent survey that showed that most Americans don't actually have liquid assets or savings to pay for costs related to emergencies. In this survey, Americans were asked whether they could come up with $1,000 to pay for an emergency room visit or car repair, and only 40% of patients or of Americans were able to say that they could pay $1,000 up front. Most people, 60%, would have to pay $1,000 for an emergency room visit, for example, through credit card financing, borrowing money, loans, so on. And so it's the confluence of all of these factors that I think has resulted in this problem of financial toxicity. So high out-of-pocket medical and non-medical spending, the indirect costs related to lost employment and income as a result of cancer diagnosis and treatment, mediated, of course, by pre-diagnosis financial status, that ultimately results in this constellation of symptoms, including difficulty meeting household expenses, anxiety and worry related to the cost of cancer care, poor credit, debt, and bankruptcy. A number of studies have suggested that cancer patients are uniquely vulnerable to financial hardship and toxicity due to the high cost of drugs, but also the chronicity and intensity of treatment over time. We are learning that financial hardship is a problem for patients regardless of health insurance status or type and income level, so it can affect everybody. And it's surprisingly prevalent. In a study we did in 2012 in Washington State, we surveyed colon cancer patients and found that 40% of these patients reported a major financial hardship during or after treatment. And that was defined as accrual of debt, a substantial loss in income, selling one's home, taking out loans to pay for cancer treatment. The good news is I think there's a growing awareness of this problem in the oncology community, starting with, in 2009, the ASCO Cost of Cancer Care Task Force guidance statement, really emphasizing that the oncology community needs to recognize financial toxicity as a problem. And more recently, the NCI-PDQ on this topic of financial toxicity in 2016. But I think there's a lot still to be done. There are many limitations of studies on this topic that have been done so far. First, many have focused on a single measure of financial status, such as bankruptcy or debt. There's limited information on caregiver or household financial impact. We don't have a great understanding of how financial toxicity might affect certain health outcomes, such as health-related quality of life, And most of the studies have been retrospective, focusing on financial status at a single time point in the past. And I think we can do better. And this is really where our work in SWOG has come into play, trying to normalize the collection of financial outcomes in cancer care prospectively in real time, and the recognition that that SWOG can take the lead in studying this increasingly important problem. So enter the 2012 Charles A. Coltman Fellowship Award, which I was really honored to receive shortly after I moved to Seattle. And this award was really instrumental in developing the study that I'm going to talk to you about shortly, S1417CD, which is a prospective assessment of financial outcomes in patients with metastatic colorectal cancer. But importantly, this award really enabled me to have strong mentorship from Dr. Scott Ramsey and Dr. Don Hirschman, the co-leads of the Cancer Care Delivery Committee, an improved understanding of SWOG and NCORP and clinical trials in general, connections and collaborations with other investigators, protected research time to develop this concept and protocol, and importantly, a stepping stone for other grants, including an ASCO Career Development Award and two grants through the Safeway Foundation. So what is S1417CD? This is a prospective observational cohort study being conducted in newly diagnosed metastatic colorectal cancer patients at all NCORP components and subcomponents. The overall goal of the study is to paint a picture of household financial status beginning at diagnosis through questionnaires that are administered longitudinally, including questions on employment, insurance, assets, out-of-pocket expenses. Many questions have been taken from previously validated questionnaires, as well as credit report data at multiple time points during the context of this study, which really gives some objective data on financial status, including credit card balances, past due amounts, liens, bankruptcies, and repossessions. Our primary objective is to estimate the incidence of treatment-related financial hardship over the course of 12 months, which we defined as debt, bankruptcy, an income decline of 20% or more, loans, and non-adherence due to cost. And then a number of secondary objectives, including determining risk factors for financial hardship in this population, studying the association between financial hardship and health-related quality of life, and determining the feasibility of engaging primary caregivers in this work to measure their perceptions around cancer treatment costs. This is the basic schema. Again, metastatic colorectal cancer patients within 120 days of diagnosis are enrolled, and administered questionnaires and credit reports are obtained over time. Our accrual goal is 374 for a sample size of 320, taking into account the competing risk of death and an estimated incidence of financial hardship at 1 year around 40% based on our previous work. So it would be lying for me to say that this was a quick and easy process activating S1417CD, but I think it was a very important and educational process. I received the Coltman Fellowship in 2012, and this study activated in April 2016. Much of this time was actually spent developing a process to obtain consumer credit reports through a partnership with TransUnion, which is a large commercial credit reporting agency. And this was never been done before. Consumer credit reports have never been linked prospectively with patient data. And so this required legal review, contracts. We had to address patient privacy concerns due to the need to collect Social Security numbers. And then we had to have assurances that obtaining credit reports for research would not affect credit scores. And I think I can't emphasize enough how great the SWOG group was in trying to figure this process out. But the other challenge was, will patients agree to share financial information? And so this was an unknown, and indeed, after the study opened, accrual was fairly slow for the first year, but really due to the efforts of the NCORP investigators, research staff, accrual has really blossomed. And to date, 220 patients are enrolled in the study, 75% from the SWOG and NCORP. We're enrolling about 5 patients per week, roughly. And at this rate, we anticipate completing enrollment in 7 to 8 months, which is really amazing and I think would be a huge success for SWOG to conduct the first cooperative group study assessing financial outcomes in cancer patients and caregivers across the country at diverse community practices. And these findings should be highly generalizable. Within the Cancer Care Delivery Committee, we're working on trying to design interventions now to mitigate financial toxicity, moving beyond describing the problem. And so we are working on a concept of a randomized trial of a financial navigation intervention for cancer patients and caregivers with the idea that providing financial literacy counseling and care access and coverage beginning at diagnosis can improve patient and caregiver outcomes, including household financial outcomes, quality of life, adherence to treatment, and even bereaved caregiver financial status. So in summary, S1417 CD, I think, is a new and exciting direction in cancer care delivery research in SWOG, really made possible by the Coltman Fellowship, which I am grateful for. Strong mentorship, amazing SWOG teamwork, and proactive and passionate NCORP investigators and research staff. And this is not an exhaustive list, but I would like to acknowledge my mentors, collaborators in SWOG, and at Fred Hutch. Thank you.